Hello, everybody. I'm Gillian Fyles. I'm a palliative care physician in British Columbia, Canada. Welcome. I'm going to talk to you about the management of nausea, vomiting, and dyspnea, which is also known as breathlessness in palliative care. And my colleague Fatima Ladha will also give us some information as well. So, by the end of this session, what we hope you'll be able to do is to list the common causes of nausea and vomiting and breathlessness in palliative care, develop a management plan, including both pharmaceutical, pharmacologic, and non-pharmacologic options for managing these situations. So how common is nausea and vomiting? Certainly with patients with advanced cancer, 40 to 60% of those patients will experience nausea and or vomiting. But this also occurs in the non-cancer setting, not just cancer. And this is especially so if patients you're caring for with non-cancer diagnoses start strong painkillers, the opioid painkillers. I'll talk about that in a minute. About a third of patients starting opioids will experience nausea at the beginning, but it usually gets better after 3 to 5 days, and you just need to make people aware of this so they don't stop after a couple of doses because they don't think it's going to get better. It generally does, but you may have to add an anti-nauseant, and we will talk about the best ones for that situation. So what's our role? And this is a photograph of one of the social workers in Hyderabad seeing a patient at home. So our role as healthcare providers is to assess the patient, determine the probable mechanism of the nausea and vomiting, because that will lead you to the neurotransmitter causing it, which will then lead you to the best medication to start with. Obviously, treating and following up is part of our role as well. This is a busy slide. You don't have to spend a whole lot of time on that, but it just is showing you that in the center, that's the brain, and vomiting, nausea and vomiting is controlled by the vomiting center in the brain, and it recognizes 4 neurotransmitters: acetylcholine, dopamine, histamine, and 5-HT2 is serotonin. It recognizes these in the blood, and they tell the vomiting center to be nauseated and to vomit. So what we're going to be talking about as we go through is what causes those 4 neurotransmitters to be released, how to block them, and how to identify which one is the major problem. And on the right and bottom right and bottom left are the commonest causes of nausea in the palliative setting. And we're going to go through this in more detail in a moment. But particularly drugs, biochemical changes, gut reasons are the 3 commonest causes of nausea and vomiting in the palliative setting. Certainly brain involvement, brain metastases, or primary brain cancers can also be involved. Less commonly is involvement of the vestibular apparatus, and we'll talk about that in a moment as well. So, causes of nausea and vomiting, and it's not uncommon for in an individual patient to find that they have a number of different causes contributing to the nausea and vomiting. For instance, a cancer patient who's just started morphine or tramadol for their pain may have nausea initially from that. They may also have high calcium, which is contributing. So when I see a patient and think about what the cause of nausea and vomiting is, I think of 5 different causes. And I'm going to summarize those at the end. Starting with chemical. So drugs, I talked to you about opioids. Also chemotherapy obviously can cause nausea, vomiting. Medications that are used for other reasons like digoxin, non-steroidal anti-inflammatory agents, ibuprofen, very commonly used. The SSRIs, which are antidepressants, very commonly can cause nausea. So you need to think about all those as being potential contributors. And the next major category is metabolic causes. So high calcium, particularly in the cancer setting, renal failure, liver failure, those are the common ones. And those can occur together, certainly. The third big contributor is GI changes. So alterations in gut motility, distortion of the gut. And you'll see I've put dopamine in brackets besides those two major categories, because for drug and metabolic causes, dopamine is the neurotransmitter that's usually that's released, and that's when you want to block. For GI alterations, again, dopamine gets released, but so does serotonin. So specifically, what changes in the gastrointestinal tract can make you nauseated? So gastric stasis, and that's basically when the stomach gets lazy and baggy. And this can happen with strong painkiller, with the opioids. And you can establish that by asking the person if they get full really fast, if they just take a little bit of fluid or a little bit of food and then they're really full. That's called early satiety, and that is an indication that the stomach may just not be contracting very well. Liver metastases can cause that as well by putting a little bit of pressure on the upper gut. Severe constipation can contribute to nausea. Clearly, bowel obstruction, ulceration, radiation, and I taught you about chemo as well. The next major category is brain involvement. So increased intracranial pressure either from a primary brain tumor or metastatic, or from bone metastases to the skull that have started to press on the brain. And sometimes you'll get the nausea and vomiting from brain involvement before you get the headache, which is common. So the fifth, but least common and relevant cause of nausea and vomiting in the palliative setting are vestibular disorders. So motion-induced, cerebellar involvement, the cerebellum is part of the brain at the back, can also make you nauseated. So as you're seeing the patient, I'm gonna go next slide. So what you're going to do is you're going to use your history and physical to try to determine which of those 5 main categories or combination of those categories are contributing to the nausea and vomiting. So you're going to talk to the patient about when it came on. So did it start within a day or two of starting the tramadol or morphine? You're going to ask about severity, because this is going to help you follow up and determine whether your medications and interventions are helping. You're going to find out if they've got that feeling of fullness, find out if they're dehydrated. Are they severely dehydrated and their kidney function may be impacted? Obviously, you're going to ask about abdominal pain, any symptoms of reflux or ulcers. You're going to look for any brain CNS symptoms, constipation, and you're going to ask people about their medications. On the physical exam side, you're obviously going to focus on the abdomen, but you're going to do a general overview because you don't want to miss signs of brain involvement. Oral mucositis, candidiasis in the mouth can contribute as well. And these are things you don't want to miss. So that's part of your assessment. And again, investigations. Only do those investigations, only send the patient for bloods, only do CTs, x-rays if it's going to change your management. If you think that the person may have high calcium or abnormal kidney and liver functions, if it's going to change what you do, look for it. You don't always need an x-ray or a CAT scan to determine if there's something going on in the gut. So think about whether it's going to change your management before sending patients for investigations. So management. To start with, try to correct the underlying cause if it's possible and again appropriate. So if it's hypercalcemia and it's appropriate to treat, and we can talk about this in the questions about how you would treat hypercalcemia, then do so. If it's appropriate to treat a bowel obstruction, do so. But if it's not, then you certainly should always treat the symptoms, even if you can't treat the underlying cause. Always look at adjusting the medications. Can you stop or reduce the medications that may be contributing to the nausea? And if it's related to the strong painkillers, try to maximize the use of adjuvants, other medications that can help with pain, to try to minimize the use or dose of the opioids. Just like you've heard about for pain management, if somebody has constant nausea and vomiting, administer the antiemetics, the nausea medications regularly, not SOS. Decide if the person can take these medications by mouth or whether you need to give them a different route, either rectally, subcutaneously through either a direct injection or a subcutaneous line can be very helpful. IV is also obviously available. Prevent and treat any constipation, and look at what's happening in the setting the person is in. Try to control odors that may be contributing. Easy things like a cool, damp cloth to the forehead, neck, or wrists can also be quite helpful. So now we're going to talk about the classes of anti-nauseants, mainly those first four. And I'm going to link that to the neurotransmitters that we talked about, dopamine, acetylcholine, serotonin, and histamine, and what drugs block what. The antidopaminergics are our favorites and the commonest. This is a busy slide, but I will summarize it. So the antidopaminergic medications are blocking the neurotransmitter dopamine, which is the one that is released with chemical causes of nausea, with drug causes of nausea, with lots of the GI causes of nausea. So they're our favorite starting drug, except in one condition, and that condition is full bowel obstruction. And that's specifically regarding metoclopramide. So metoclopramide, Paranorm is the trade name, is our favorite except for a full bowel obstruction. And it comes in parenteral and oral preparations. Extrapyramidal side effects can occur, and my colleague Fatima is going to talk to you about those in a moment. You just need to watch out for those, and those are Parkinsonian side effects. So you know about Parkinson's disease. You need to watch out for those side effects with this class of drug, and either reduce the dose or switch to another class if you have to. And it shows you on the slide the dose reduction for renal problems. Domperidone is another nice one. Now, I know that some of you have access to metoclopramide, domperidone, and haloperidol. Some of you don't. It's quite variable in Bangladesh, we understand. So domperidone, I've given you the dose there. It doesn't cross into the brain, so it's less likely to cause Parkinsonian side effects. It has the additional risk of QT prolongation, which can lead to the condition called torsade de pointes, which is a potentially lethal cardiac arrhythmia, which is why you stay at that 10 milligram TID dosing. It doesn't have a parenteral option. Haloperidol is our second line treatment in my setting when metoclopramide doesn't work. And you see the dose there. It's a very low dose compared to the doses that you'd use for delirium, for instance. And it can be given subcutaneously as well as orally. Again, it has the possibility of Parkinsonian side effects. The other ones are just other options at the bottom, but I think these drugs are perhaps less available in your settings, but I know it's variable. So the antidopaminergics are our favorites. I'm going to hand over now to Fatima to talk to you about how these drugs cause these extrapyramidal symptoms and what you can do about it.
Hello, everyone. My name is Fatima Ladha. I'm a clinical pharmacist specialist in oncology and palliative care from Canada. So a quick review of what causes extrapyramidal symptoms when managing nausea and vomiting in this patient population. So this diagram indicates you have blockage of dopamine that occurs within the nigrostriatal pathway. This blockage of dopamine will interfere with acetylcholine. As a result, you have excess acetylcholine interacting with the M1 receptors on the synapse. And as a result of that, you experience EPS symptoms. However, with the use of certain antimuscarinic drugs, you might be able to reduce or reverse the EPS symptoms caused by antidopaminergic because the antimuscarinic drugs will compete with the excess acetylcholine circulating in the synaptic cleft at the M1 receptors, and therefore it is potentially possible to reduce extrapyramidal side effects.
The next class of drugs are the anticholinergics. So these block acetylcholine. And the drugs are, there's two main ones. There's the hydrobromide patch, which is a patch that you stick behind your ear. It's used for sea voyages. It helps with nausea, motion sickness from sea voyages. But it also comes as butyl bromide, which can be given by mouth, under the skin, or rectally. These are less common. Acetylcholine is less commonly the neurotransmitter that's causing nausea and vomiting. The doses are there, and I know you have thiammonium methyl sulfate available, and that's not something that's familiar to me, but Fatima's put the doses there. We use that class of drugs, the anticholinergics, when people aren't responding to the antidopaminergics. You can add them to the antidopaminergics if you need to. Sometimes we use these for cramps as well, and in the setting of a bowel obstruction, you're not going to want to use metoclopramide, and we use these for cramping type pain as well. The third class is the antiserotonergics. Serotonin is released by cells in the gut, and it's these drugs, so it's ondansetron, palinositron, are particularly useful for nausea and vomiting secondary to chemotherapy, radiation, or after surgery. They're not the best drugs to use in other settings, but again, they can be third or fourth line. Finally, the antihistamines, so dimenhydrinate is a classic example. We know it as Gravol. It's a very commonly used medication for motion-induced nausea and vomiting. It's a bit sedating. And again, it's third or fourth. The situation where we may use it earlier is for cerebellar involvement, but it's not going to be the first one you try. Other medications can be useful. Steroids, so dexamethasone is widely available and available in a variety of routes, can be really helpful. The exact mechanism of how it works in nausea and vomiting can be unclear, or is unclear. If somebody's got a brain metastasis and swelling, you can reduce the swelling around the brain metastasis, and that can help reduce the nausea and vomiting. Benzodiazepines, and there's lots of them, can be used for anticipatory nausea. So that's a person who may walk into the clinic or the hospital to get their regular chemotherapy, and just the mere fact that they see the hospital or they know they're coming in makes them nauseated. And that's where benzodiazepines have a role. And we're not going to get into bowel obstruction, but for a patient with a full bowel obstruction, a complete bowel obstruction, a medication called octreotide, given subcutaneously, can be helpful. But that's outside of the realm of this particular discussion. I'm going to hand over now to my colleague to talk about pediatric dosing for nausea and vomiting.
Within the pediatric population, we have access to most of these medications. As you can see on this slide here, there's dosing suggestions provided for metoclopramide, domperidone, haloperidol, dexamethasone, ondansetron. The new drug here right now is ranitidine. Ranitidine, as we all know, has been on manufacturer's back order and is unavailable internationally. And I believe currently in Bangladesh, this drug therapy is banned due to the lack of availability for the medication. However, you can see the dosing here that's recommended once the ban is removed and/or the drug therapy becomes available on the international market. As an alternative, famotidine can be used. My apologies for the typo in this document here. It's famotidine. Within the different age categories, you can use this medication in infants, children that are 3 months to 1 year of age, and then children greater than 1 year of age. And it can be given orally or IV routes, depending on the requirements of the patient. Within pediatrics for nausea and vomiting, Scopolamine hydrobromide is used in other countries, but it may not be available. Same thing with hyoscine butylbromide. However, I've provided those dosings for you here just in case if there is access and availability at some point. Unfortunately, tiammonium cannot be used in children because there is no data for dosing or safety. Dimenhydrinate, commonly known as Gravol in Canada and the United States, can be given, and the dosing is there for you as well. Rectal routes for medications and nausea and vomiting are possible in the pediatric population. Many drugs can be given this way, depending on the formulation, the excipients available. However, it's recommended that you ask your local pharmacist for guidance on dosing and product availability or the necessity of compounding products for your particular patients.
So that's the pharmacologic management of nausea. What about non-pharmacologic management? I'm going to talk to you about diet modifications in a moment and taste changes, but complementary and alternative medications and herbal medications certainly can play a role here. And depending on where you live, different foodstuffs are used. So here in North America, ginger and peppermint are used to help reduce nausea. In Nepal, lemon tea is used. In Andhra Pradesh in India, lime pickle, and I've been told that in Bangladesh, cardamom is used to help reduce nausea. So use all that you have available to you in this regard. Diet modifications. Small amounts of dry foods like crackers, pretzels, toast can be helpful. Try things out. Flat fluids like flat carbonated beverages, herbal tea, water. Have patients constantly sip, have something by their bed or chair rather than taking 3 big meals a day and 3 big lots of fluid a day, constantly graze. Advice has been given to wait half an hour after vomiting, then start to sip small amounts. Don't lie down for an hour after eating. Keep the head of the bed elevated to reduce reflux. Make sure the teeth are clean and your mouth is rinsed. Some suggest avoiding the person's favorite foods when they're nauseated and vomiting so they don't have an aversion to them later, and that they can still enjoy their favorite foods once they're feeling better. Okay, so that is nausea and vomiting in the setting of palliative care, both cancer-related and non-cancer related. We're now going to talk about dyspnea, also known as breathlessness, shortness of breath. So dyspnea is the sensation of shortness of breath, and you can imagine it often makes the person feel anxious. Now, it's a subjective phenomenon, just like pain is. It's what the person says it is. So you need to get people grading it on a scale, whatever you use, 0 to 10, faces, whatever scale you use to have patients and families grade their symptom severity so you can follow it. The feeling of breathlessness doesn't necessarily correlate with the respiratory rate, although it can. Blood gas analysis and oxygen saturation doesn't always correlate with how the person feels. So this is important. It's what the only reliable measure is what the person says they're feeling, how the person says they're feeling. Again, how common is it? It occurs in about half of people referred for palliative care, and it's a symptom that we as palliative care professionals are not very good at managing. Certainly in the lung cancer population, up to 70% of people with lung cancer present with shortness of breath, and it's more common in the last weeks of life. But it also occurs frequently in people without lung involvement, and I'll talk to you about why in a moment. This is the moment. So common causes of dyspnea in palliative care. So obviously, cancer involvement of the lung or the airways, leading to obstruction, collapse, fluid in the pleural space or around the heart, infections, pneumonia. Other common non-cancer causes of shortness of breath, chronic obstructive pulmonary disease, congestive heart failure, pulmonary embolism, so blood clots to the lungs, respiratory muscle weakness. So many patients at the end stages of life are cachectic, they're very weak. They've lost so much muscle mass, and their respiratory muscles are weak, just like the rest of their muscles. Ascites, so fluid in the belly, pushing up against the diaphragms, making it difficult to get good big breath. Anemia, low hemoglobin, and anxiety can all contribute. And you can get a bunch of these causes all happening at the same time in an individual patient. Again, assessment, self-report. What does the person say it is? Grade it. Do the history, just like usual. Look for physical signs. Count the respiratory rate. Look at how the person is sitting, leaning over like that, leaning on a table, nasal flaring, indrawing, all those things can show you how distressed the person is. Do a quick overall examination. And again, only do blood work, x-rays, CTs if it's going to change your management. But just like we talked about for nausea and vomiting, you can treat the underlying cause, do so, and we're going to go through that in detail, and then we're going to go through these other categories of treatment. So again, specific treatments for the underlying cause. If a pleural or pericardial effusion, fluid in the chest or around the heart is causing it, and it's appropriate to try to drain it, do so. If the person has ascites, so lots of fluid in their belly and it's appropriate to drain it, do so. If the person has a blockage in a large airway, depending on what you can do in your setting, XRT is radiation. Sometimes that can be extremely helpful. Occasionally stents can be placed, sort of tubes. That's pretty specialized. If the person has pneumonia and it's appropriate to treat, use antibiotics, use bronchodilators for people with COPD, diuretics for people who are in heart failure, transfusions if appropriate for anemia, anticoagulation if appropriate for blood clots to the lungs. So treat what is appropriate to treat regarding the underlying cause. And then general measures, position. Help the person get into position. So I'm leaning over and I'm leaning over on my desk. That can help. Fans and open windows. And again, with COVID, there are in some locations rules about not using fans, rather use open windows. Make sure you're following the rules. But pre-COVID, using fans and or an open window can be very helpful, because what happens is the airflow over the trigeminal nerve distribution in the face can reduce breathlessness intensity. There's as well good evidence for a role of breathing retraining, and there's a number of different techniques, and the nurses, physios are very good at teaching patients and families these techniques. So diaphragmatic breathing, pursed lip breathing, relaxation techniques, and basic pacing priority setting can really be helpful for people who are very short of breath. Living situations can contribute, and I know this is maybe a very hard thing to do in your settings, to avoid stuffy rooms with no airflow. For babies and children, the position of choice. You need to look at how the baby or the child is positioning themselves, which may be the position that reduces their shortness of breath. Play therapy can be very helpful as well for children and babies. Okay, so what about medications? Opioids are the drugs of choice for the symptomatic management of breathlessness in the palliative setting. Okay, and you've heard about their use for pain from Dr. Richardson and others. Tramadol, morphine. Use these medications. You start them at a lower dose than for pain. So have the dose generally, or more, depending on the patient and the setting, but consider using opioids. There's clear evidence for their use. Same principles as for pain management, regular versus as needed, depending upon the patient. And again, lower dose than you would start for pain. And I've talked to you, you see what we're talking about, to lower your dose. And tramadol, again, you've seen this before, and the same caveats. There's a seizure risk, and we've given you the adult and the pediatric dosing, but again, reduce the dose to about half of what you would do for pain. What about other medications? Steroids, again, steroids or dexamethasone can be very helpful. Again, they can be given orally, subcutaneously, or IV. And again, that's the usual doses, 4 to 8 milligrams once daily. Give it all in the morning. Don't need to give the dose split during the day. And steroids can be useful if the dyspnea is related to a bronchial obstruction, because it can reduce swelling. Inflammation from radiation, reducing swelling. SVC is superior vena cava obstruction, where generally a tumor is blocking the superior vena cava. In addition to hopefully offering the patient radiation, steroids can reduce the swelling. Lymphangitic carcinomatosis is a situation where the cancer is going all through the lymph channels, and steroids can be helpful, may be helpful in that setting as well. What about benzodiazepines, lorazepam, and others? Many people will feel anxious when they have breathlessness. It's important to treat the anxiety to help reduce the burden, okay? There's lorazepam, which can be used orally. There's midazolam, very short acting, that can be used in a number of different ways to treat these symptoms if they are severe. What about oxygen? It's automatic when somebody comes into an emergency room breathless to have oxygen put on them. In the palliative setting, it may be helpful, but not always. There's evidence for the use of oxygen in the hypoxic terminally ill cancer patient, and it can be helpful in COPD and hypoxia. Keep in mind people who may have high CO2. In other situations, however, it's not so clear, and air may be just as effective. So the open window, the fan, if allowed in the setting of COVID, may be just as effective. Okay, that's the summary of nausea and vomiting in palliative care and breathlessness in palliative care. We'll be happy to answer any questions